Our second case for our panel today is a 1.5-year-old with dysphagia and oral aspiration, laryngomalacia, chronic cough, obstructive sleep apnea, and drooling. And the story is that this child presented early on with cough, choking, stridor, quite early in the first month of life. And a video fluoroscopic study at the time, or a little bit later at 3 months of age, showed moderate dysphagia and oral aspiration up to 3/4 honey consistency. An upper GI performed at that time showed normal anatomy, no vascular rings or other structural problems. Eventually, at approximately 12 months of age, he was seen by our aerodigestive multidisciplinary clinic with persistent symptoms and also noted reportedly to have severe snoring. His growth and development and feeding cues were quite typical at the time. Next slide. So we proceeded with aerodigestive procedures at 13 months of age. Upper endoscopy or EGD was normal, including biopsies. A flexible bronchoscopy was normal, including bronchoalveolar lavage, microlaryngoscopy, bronchoscopy, and drug-induced sleep endoscopy by ENT showed laryngomalacia and no other significant abnormalities. He underwent a supraglottoplasty and adenoidectomy for adenoids hypertrophy. And at 16 months of age, he presented back to the aerodigestive team with the following symptoms. He underwent our thickener wean protocol with our dysphagia team here at Phoenix Children's Hospital, and he was now able to swallow water and thin liquids and smoothies and thin yogurts without choking. However, prior to the procedures, he had been able to eat a variety of foods, soft foods, but after the procedures, he had trouble swallowing the same solid foods that he was able to eat pre-procedure and would choke and spit up. We, at that point, proceeded with a second swallow study, and the swallows were definitely normal. There was no dysphagia noted and no aspiration, but he was noted to be quite anxious. The snoring definitely had improved. However, he had persistent cough, which was not responsive to bronchodilators and inhaled steroids. And he had this persistent drooling problem. So at this point, I'm just going to, and both of our cases were actual patients at the aerodigestive and feeding program. So I was going to introduce our panelists. Dr. Jim Woodward is our pulmonologist in the aerodigestive clinic. He's also one of the founders of our aerodigestive program at Phoenix Children's Hospital. Everybody knows Dr. Rachel Rosen. Dr. Mark Gerber is our surgical director of our aerodigestive program and also the chief of the otolaryngology department at Phoenix Children's Hospital. Everybody has met Stacy, who is a leader in speech and language pathologist and a dysphagia specialist. And Rachel Goodwin, a rising star dietitian, very involved with both the feeding program and the aerodigestive program at PCH. So we have, next slide, we have prepared some rapid fire questions. And of course, we can go into a discussion based on everybody's impression and some ideas that may come up from that. But I'm going to start with Dr. Woodward. What is your perspective in laryngomalacia, one of the very few findings we're left with in this child causing chronic cough?
So usually laryngomalacia causes stridor on inspiration, not so much cough, but the laryngomalacia could be causing dysphagia, leading to some inflammation that could cause the cough. I mean, this generally you see laryngomalacia during the first year slowly get better. So from the presentation, it sounded like stridor was initially there in the first month or so. Generally, you see it to improve. Generally, by in the second year of life, laryngomalacia gets better on its own. Clearly, there was still some, so the supraglottoplasty would have helped that. I'd be more concerned about the cough coming from dysphagia than I would from laryngomalacia. A lot of times we use bronchodilators and inhaled steroids when there's lots of cough involved in these kids, but there was not any response to that therapy as far as this cough, so it's unlikely that continuing those kind of medications is going to be the answer. So I think the dysphagia is more likely the cause of the chronic cough.
Well, great segue into Dr. Rosen. And we are wondering your thoughts on esophageal dysmotility causing a chronic cough in this child and obviously drooling. And what would be your approach if this child was evaluated at Boston Children's?
So there's a couple of things to think about, one of which is the age, and one of which is this kid was taking solid food before. So it would be very unlikely for this kid to develop out of the blue within 3 months a motility disorder in a 1.5-year-old. So, just history-wise, there's almost nothing that would cause that from a primary motility disorder. Now, one of the things that's often tricky is what else changed right after the adenoidectomy. So, for example, was the kid previously on and understanding the medication history is tricky. If kids, for example, were on inhaled Flovent because of their respiratory symptoms and then got their adenoids taken out and somebody stopped their Flovent, well, then you might have been treating EOE that now has reared its head when you stop the Flovent that was originally treating the lung issues, but probably was treating the esophagus too. So I guess what I would ask is if something else changed immediately after the adenoidectomy and supraglottoplasty that would have triggered all of a sudden a change. I can think of very few esophageal things would happen out of the blue other than EOE. So has the family introduced new foods that the first scope was done without that new food in their diet, and now the new food is in and now they've developed EOE. But again, the timeline is a little strange. If you are worried about esophageal dysmotility, this would not be a kid that I would rush to do an esophageal motility study on. I would absolutely do a nuclear medicine esophagram, giving this kid, for example, mac and cheese, or we use also scrambled egg with nuclear tracer, and see if it's getting hung up in the esophagus. If it is not, I would not put this kid through an esophageal motility study that I think honestly would be traumatic. You also have to remember when you're doing esophageal motility studies, you have to look closely at the timing of tonsillectomy and adenoidectomy. So we need at least a couple months between those procedures before we would do an esophageal motility study. This kid is within that window, so it would be okay. But just so you know, we often get asked, can you just put a motility catheter in at the same scope that you're doing the adenoids? And the answer is no. We're not sticking something in the nose at the time that they're doing an adenoidectomy. So again, you just need to think about the timing in this, but I would start with very uninvasive testing because my index of suspicion is low.
Excellent. Dr. Gerber, what is your perspective on this case? What are the benefits of supraglottoplasty, adenoidectomy? Is there an indication for surgical laryngomalacia repair? Any other considerations for treatment of drooling?
So they're good questions. I have a feeling that in a 13-month-old, where they weren't describing a lot of stridor, they were actually treating sleep state laryngomalacia, which they probably saw on the DICE, on the drug-induced sleep endoscopy. So if they saw a moderate-sized adenoid and some collapse at the larynx, then I think it's very reasonable to open that up a little bit and reduce the sleep state laryngomalacia, which might have been contributing to the sleep apnea symptoms that the child was having, but much less likely to be an issue in terms of swallowing. It is, I think Rachel's point, Dr. Rosen's point is absolutely on target, is what else? What are we missing in that history that helps explain the change from pre-op to post-op? Because in adenoidectomy and supraglotoplasty, there's been pretty good studies looking at whether there's dysphagia before a supraglotoplasty, dysphagia and aspiration before and after. If they swallowed well before, they swallow fine after. If they had aspiration before, they sometimes got better, but sometimes continued to have aspiration after. So, and also, as Dr. Woodward said, this child's a little bit on the older side for the classic laryngomalacia that we will do when the kids are much younger for stridor and upper airway obstructive symptoms during the early infancy or neonatal timeframe. Yeah, my biggest questions are what else? What else on that history are we missing? The drooling makes me think of dysphagia. Why are we starting to drool now and did not before? I love that thought process in terms of the inhaled steroids that may have been utilized prior to surgery because we were trying to do anything we could to avoid surgery. So you do inhaled steroids, we'll do nasal steroids. I can't say that I've ever seen a child just with nasal steroids get enough into the nasopharynx, into the oral pharynx to manage or to mask EOE, but these are babies. And so at age 1, maybe there was enough even being swallowed, and then the Flonase comes off and now you've unmasked something. So.
Dr. Gerber, what is the amount of pain that a young child would experience from adenoidectomy?
Usually it's really mild. Yeah, we talk about a couple of days. It's not like a tonsillectomy where they're sore for days and days. The kids are usually back to normal diet, normal activity in a couple of days. They can have bad breath for about 10 days for a while the scab's up in the back of the nose healing. But we don't see significant pain and discomfort from an adenoidectomy alone in general. There's exceptions to that, don't get me wrong, but that's not common.
Excellent. So Stacy, you're up, which makes you, it sounds like all roads lead to dysphagia. So first of all, I wanted to also start with a question because I am being called on this, which I absolutely love because I'm old-fashioned with the three-quarter honey. So one of our attendees really asked the question of how we would figure out three-quarter strength honey, how we would measure it, and how does that correlate on a IDD-SI scale. So hopefully you can clarify that in your perspective, but also your perspective on feeding problems post adenoidectomy. Are there any risk factors in those kids that may have been anxious and we just didn't know about, or any skill changes that could happen as a result of those procedures?
Yeah, thank you for asking the question about the thickening. I saw that pop up and I wrote it down myself to be able to address. So I guess first looking at the feeding problems post adenoidectomy, usually we see, before adenoidectomy, problems with swallowing solid foods because of possible obstructions or coordination with breathing and things like that. So for it to happen after the fact is a bit unusual, unless it would be because of some associated pain early on, and causing them to have some anxiety or some fear with swallowing again. Obviously, you take something out of the nose and the back of the throat and it changes their anatomy and things feel different. So I would like to see what their skills are as far as bolus control, how they were chewing before, how they were, and then how they're chewing and managing those solid foods now. Are they chewing well enough? Are they trying to swallow too quickly? Are they losing control in their mouth with these solid foods that are making them more anxious? But also with going back to the drooling issues too, they were swallowing all of that fine before, which goes back to what Dr. Rosen had mentioned too, maybe they're older now, quite a bit older. Maybe they're eating different foods that are causing, you know, risk for EOE or some other kind of reaction to foods that's making it harder to swallow or making them more fearful to swallow. And with the drooling, I would like to see, you know, are they drooling more, you know, while they're eating, while they're sleeping, while they're playing? Are they still keeping that open mouth posture at play? Because it's what they did before. If they were obstructed in their nose, a lot of these kids are open mouth breathers. So we would want to look at their oral structures to see how what their tongue, lip, and jaw are doing, how they're sleeping. Are they still sleeping open mouth? Are they sleeping with their mouth closed? Are they playing with their mouth and tongue out, or are they getting some more semblance of some closure? And that would be a therapeutic thing to work on. If they are not, is to work on that sensory awareness and their awareness of their oral structures and getting them some better tone and some better movement in there to be able to control and have awareness of that saliva. So going to the question of the 3/4 honey, that is something that is a fairly newer term to me, being here at Phoenix Children's Hospital too. But when we measure it from IDDSI perspective, it's right at the low end of honey, so right around that 8. Or the high end of a nectar. So between that 7, like right at that 8-ish. So on the thin end of honey, higher end of nectar, that in between kind of stage. We tend to use that thickness of liquids for our little ones that we're a little hesitant to put on a full honey consistency or that moderately thick consistency because of hydration issues and because of endurance and being able to sustain themselves to be able to take the volume over time without fatigue. So we found that to be a nice middle ground kind of measurement. So if we're doing IDDSI, it's on that higher echelon of the nectar to that lower, like right at that 7-8 measurement for the IDDSI.
Awesome. And I'm going to, before we go to Rachel, I think Jen was going to join us. Are you with us now, Jen?
Yeah. Yes, I'm here. Sorry.
Okay. So it so happens the follow-up is that the child started our intensive feeding program, and we're really, it's a modified, so it's not a daily, you know, very intensive, but definitely more intensive to really get to the bottom of this new feeding issue. And we're definitely going to scope him again. So thank you, Dr. Rosen, for that thought. But we also have noticed sort of those anxious tendencies. And so I was just going to have Jen kind of update us on some of her thoughts that she had as she's starting to work with him.
Yeah, surprisingly, there's a huge sensory piece on this particular child. I'm not sure how well he ate before. Mom reported that he ate. But now that we've gotten to the point where we see him more frequently, we've discovered that not only does he have very, very little skill, and the only foods he eats are chips. He'll eat like a variety of chips and yogurt. And he gags on, he will eat the yogurt that has fruit chunks in it, but he ends up gagging on them. So first is a sensory piece where we have to get him to put the food in his mouth, something new and different, which is literally a chip that looks like another chip, but it's slightly different. And then once he gets it in his mouth, trying to get him to do some oral motor skills because he is at an age where he can understand. But he's been a little tricky. The other piece that baffles me as a therapist is that he also, and I don't know if this was in the presentation of the case, but he also comes in, he does not have any enteral tube feeding, and he will go 12, 15 hours without eating. So that becomes, you know, mom comes in, she's sleep deprived, she's exhausted. he won't even eat like a bag of chips, you know, from 8 in the morning to 8 at night, and then he's starving, and then he'll drink a yogurt, and that's it. So we're really racing the clock on this one as far as that goes. So the sensory piece has been big. He's a sensory seeking kind of kid, and we're trying to help her maybe regulate some of those states within the home to help maybe drive some hunger, but that's not been terribly effective so far.
So I just wanted to emphasize how the team perspective with this case was able to identify characteristics of the child that were not obvious from the beginning. And you can imagine that if this child would have been managed outside the team, of how there would have been a tendency of, oh, maybe it's asthma. No, it's not asthma, it's the adenoids. Oh, they need to see an ENT. The ENT says, no, it can't be the adenoids. You know, he's a typically developing child. He's, and this whole drooling, it must be sensory, and sensory, you know, so really emphasizing the importance and the value of the team approach. And back to Rachel now, you know, obviously we have a child that's actually very selective now, and how do we approach that from a nutritional perspective? And of course, in this case, incidentally, those symptoms were noted or were perceived as occurring after the procedures, but they were probably, there was probably more to the history that we didn't know before the procedures as far as their feeding history. So Rachel, what are some things that you consider important in addressing in a child like this?
Yeah, I think one of the things that I like with this is, you know, we had kind of the story of like when he first presented to the Aero Digestive Clinic, and then now, you know, he had workup and things, and to kind of see where we are, and being a part of that multidisciplinary clinic as a dietitian, you know, we're trying to do our full assessment at each visit. And so from that standpoint, I like that from our initial visit, we have a good documentation of what his baseline was prior to the procedures. So we can use that to really go off of and compare things back to, you know, and when we're doing our assessment, we're looking at, you know, so many different things, you know, starting with the, you know, just basic physical assessment, looking at the growth chart. It looked like on the report, growth hadn't really been part of the picture, but you know, the growth chart is only one piece of the picture. It doesn't always tell you what lengths families are going to maybe achieve the growth pattern that you're seeing, or, you know, what diversity of foods perhaps the child is eating. You know, Jen mentioned chips. Like, we definitely have seen children who literally have, you know, a food variety of like 2 foods that just happen to be so calorically dense that their growth chart seems appropriate, but you can definitely identify some other very bright red flags waving when you start doing your assessment. And because it's the follow-up, you know, you really have that curve over time at PCH2. And I think now with COVID, we all understand the difficulties of telemedicine visits and things like that. And so for as much as possible, when we do have these visits, which currently our Aero Digestive Clinic visits tend to be in person, which is nice because we can get those accurate anthropometric data. It can be very helpful. And then we always are asking about their nutrition history. You know, what's the quality of the foods they eat, trying to get a feel for the quantity of foods that they eat, and then the frequency, because all those things can really interplay in getting a full picture of what they're eating. It's helpful to get the feeding history, you know, what were things like as an infant, even prior to his first Aero Digestive Clinic, and then getting that interim history of what really changed, and being able to loop things back to the family, and going off that previous assessment to say, you know, you previously said he ate X, Y, and Z, and hearing their report about, oh, he does eat that too, I forgot, or no, he completely lost that food, and all of that's really important information to gain. Plus, of course, you have the social, economic, environmental factors that could have changed in the meantime too. And then when we're seeing him again, I want to get a good assessment of what he's doing currently, because when you can put all those factors together, it helps you figure out what the interventions are going to be. And then I'm grateful for the interdisciplinary team because I can, you know, reach out to my feeding therapist and say, you know, how is he doing? And they can reach out to me and say, I have some concerns. And I think this is a ticking time clock, you know, like Jen mentioned, and we can kind of collaborate together and then with the family to figure out what kind of interventions are going to be best in terms of, you know, are we just looking at broadening our dietary diversity? Is that something we can do in therapy? What would the timeline be for that based on what they're seeing in their assessment? Versus do we need to look at oral nutrition supplements? What would be the most appropriate versus are we talking something a little bit further along the path in terms of like tube feedings or things like that? And so thankfully those are decisions that we can come to together as a team.
Awesome. Any other comments from any of our panelists? So Rachel, there's one more question for you. We have absolutely 2 more minutes before Jen takes over and Dr. Scheffler goes on. And that is if you can make a quick comment on the dietary implications of thickening liquids to 3/4 nectar in this child, even though this particular child underwent the thickener wean protocol and they are not currently on thickeners. But I think that was a good point to make for those of us there, particularly speech and language pathologists that may wonder, you know, sometimes the treatment maybe has to be scrutinized very carefully because of implications in other domains.
I'm assuming this is a question for me, Rachel, in terms of 3/4 honey. And so I think it's really important to understand what thickener are you using to get to 3/4 honey, because it can really be different. You know, if we were to say that this thickener, we're just going to kind of talk theoreticals about some of the different options and how they vary. If you were to do a 3/4 honey, which, you know, like Stacy had described, is kind of on the thicker end of that scale, you're using a pretty good amount of cereal. And so we're thinking, you know, what does infant cereal contain and how does that affect fluids? And so, you know, thankfully it doesn't affect the free fluids. I think the research shows that the body is still able to absorb the fluids, even if it's bound to the cereal through the digestion process. But that can be a significant amount of calories. You know, if you're starting off with, let's say you were thickening infant formula or whole milk, you know, something that's like 20 calories per ounce. If you're going to something like a 3/4 honey, you're probably looking at adding an extra 10 calories per ounce because of that level of thickness. And so that's definitely a substantial amount of calories. And so I think with that first part of the assessment, that's part of the piece that we're looking at is, you know, if they were on thickened liquids and they're growing, how much of that is just related to the calories and like the carbohydrate in rice cereal versus maybe the more balanced nutrition they were getting if it was, you know, a formula or breast milk, let's say, and they were using gel mix. Some of the other thickeners that are available, both kind of in the infant realm, but once you pass 12 months of age, there are other thickeners that are available as well with different bases. And some of those also contain fiber. And so that's something else that you need to be mindful of, you know, how much fiber is probably going to be a reasonable amount. And again, that comes into collaboration with GI. What do they think is safe with, you know, medical history? How is there any compromise with gut perfusion in terms of doing thickeners that are on that high level of the scale? You know, Dr. Rosen mentioned you can do fruit purees. Depending on how much fruit puree you're adding, or you do need to worry about diarrhea. So there really are so many different components to think about because there are so many different thickeners that you could think about at so many different levels too. And so I think those thickener levels too depend on, you know, if we're using it for dysphagia like we are in this patient versus if it's something that's used more for reflux, which is something that we were kind of talking about more for that, for the first case as well. That's usually a lower level of thickening that we would be thinking about.